the prostate biopsy is the only way right now in which we can diagnose prostate cancer. And it's one of those things that continues to strike fear in men because they worry about actually having an ultrasound actually in the rectum and actually needles going into the prostate, which is totally understandable. If you talk to men 10, 15 years ago, it was a far more traumatic experience for them than it is these days. And I'll tell you why. It's because we've gotten a whole lot better at actually doing the anesthesia around that. So let's kind of walk ourselves through what a prostate biopsy is. Well, first of all, we've talked about this, that we're doing a prostate biopsy to diagnose prostate cancer. We actually have to get tissue from the prostate to get to the pathologist so that pathologist can actually diagnose that man and hopefully not diagnose that man with prostate cancer. So that we've got to get tissue. And the way we do that is we'll do an ultrasound. It's like a rectal exam. It's a small little ultrasound that actually goes in the rectum. And I tell people it's like a 10-minute rectal exam. That ultrasound goes in the rectum, and then we actually look at the prostate. We then numb up around the prostate. At USMD, we actually specifically target areas in the prostate. And we'll go into specific zones. And then after we numb it up, we'll target those areas and then, again, biopsy those. And then that will actually go to the pathologist. And then, again, that pathology, we usually get that back and give or take anywhere between, 4 to 7 days. So what are the problems with this? I mean, number one is the fact of, we want to make sure that it's as comfortable as possible. I certainly can't call this a comfortable experience by any stretch of the imagination, but we're going to make it, relatively as mildly uncomfortable as possible just from the ultrasound itself. So what we do is we have to worry about several things. Part one is we want to make sure that we minimize the risk of infection. So what we've found over the last, give or take 10, 15 years, and certainly over the last 5 to 6 years, one of the hot topics about prostate biopsies is infection. Well, why are you going to get an infection? Why is there a risk for infection? Anytime we do any kind of invasive procedures for, men or women or anybody for that matter, there's always the risk of infection. There's an increased risk of infection for men undergoing a prostate biopsy because that ultrasound, as well as those needles, will actually go through the rectum. And as everybody knows, the rectum and the colon actually contains bacteria. Well, so what we do as the urology community-wise is we will give that patient some antibiotics that will actually get in that patient's bloodstream. So if indeed, when we do the biopsy, it'll minimize the chance, and that antibiotics will actually hopefully take care of that bacteria that is going to temporarily arise from, and again, get potentially in the bloodstream, and that bacteria we've got antibiotics on board to again, fight that bacteria. And that's going to minimize that chance of actually getting an infection. But what happened? Why did things change over the last give or take 5 or 10 years, certainly the last 5 years? And one of the reasons why is that we became overzealous with antibiotics. We're giving antibiotics for everything. We give antibiotics for a runny nose, even though it could be a virus. And the same thing actually happens for men. If we treat men with antibiotics and then we try to give them the same antibiotic before this procedure, what happens is you actually can become resistant to that antibiotic. So what does resistance mean? Resistance means that you actually now have antibiotics on board. Your bugs and the bacteria sitting in your colon says, look, I'm smarter than you. And so if you try to give me that antibiotic again, I'm actually not going to be sensitive to that, i.e. it's not going to work, and I need a different antibiotic. So as we use more and more antibiotics, and in particular, everybody knows about ciprofloxacin. Also, there's another one that's very similar called levofloxacin, also known as Levaquin. Okay, both of those are very similar drugs, and they're called quinolones. So if a man's been treated with that, okay, and routinely in the last 6 months to a year prior to that biopsy, and he gets the same antibiotic, and that man undergoes that biopsy, what can happen is he's at increased risk of that resistance. And if he's at increased risk of that resistance, then what happens is he can end up getting an infection afterwards. Okay, so what we've seen is that infection rate has increased. It was as low as about 1 or 2%. It's bumped up to as high as about 8%, and sometimes even as high as 12% in specific studies. So we want to minimize that risk of infection. That's the number one thing that we worry about for patients undergoing a prostate biopsy. Obviously, comfort-wise is up there as too. We certainly can't demean that any whatsoever. But the infection rate is clearly the number one thing, or the number two thing that we're thinking about. How do we minimize that? Well, I can tell you what we do at USMD is you got a couple of different choices. What we do is we will ask that patient if they have actually been exposed or actually been treated with either ciprofloxacin or Levaquin prior. That's our gold standard drug that we use. we'll give them routinely Levaquin, which is a little bit better than Cipro, but very, very similar. And we'll give that to them before we do the biopsy. So we've got to get in their bloodstream. So if they come in and they say, I'm ready for the biopsy, the first thing we're going to do is make sure they take their antibiotic. And again, whether they're going to get that pill or not. If they've been exposed to that, we're going to give them a shot. Routinely, we'll give them Rocephin, which is what's called a cephalosporin. It's very similar to a penicillin. If they're allergic to penicillin, already had the Levaquin, then we give them another antibiotic. But the whole point of this is that patients are at risk of developing an infection because we're seeing that resistance pattern get higher and higher. So what I tell patients, if they're coming to see us, we're going to go through this regardless. But if you're going to go see a urologist, the first question you want to ask them is, after they say, hey, Mr. Jones, you need a biopsy, the number one question is, okay, is there, do you know what your infection risk pattern is? Number one, because we want to know, again, ours right now at USMD is less than 1%, and we work pretty hard at that. And the second question you want to know is, what antibiotics are you going to give me? And the third question is that appropriate for me? So we want to make sure that, again, these patients are at a decreased risk of actually getting an infection, from the biopsy wise. So there's a system in place to minimize their chance of actually getting an infection. So that's part one. Now you can actually take the next step, and some guys are actually doing this. And the next step for this is actually, it's a little bit more invasive, where we say, all right, Mr. Jones, we're going to do a biopsy on you next week. But we want to find out in the rectal flora, which is the bacteria that's sitting inside your colon, we actually want to see exactly what kind of resistance patterns there are with the bacteria that's sitting in your colon. So they'll do a rectal exam on you, and then they actually send that in for culture, and they try to figure out, is there a resistance pattern present within that bacteria that would subsequently increase that patient's risk of developing an infection. So, that's a bit aggressive, and it's certainly considered, and several clinics do that, but it's certainly not a bad way for certainly patients who have had a really tough time on their first biopsy. So part one, again, comfort level. Part two is looking at how do we minimize that patient from actually getting an infection, which we talked about. Make sure you talk to your doctor about which antibiotic is appropriate for you. And then the third thing is bleeding. Anytime we put needles in anybody, whether it's going to be, a blood draw, but certainly in the prostate, which is a very vascular organ, we want to make sure that we're minimizing the chance of actually having any bleeding from that area. There is some debate on here, whether patients actually need to stop taking aspirin or not. We try to go on the side of caution, which we try to get patients to stop blood thinners if at all possible, because there is a increased risk of having bleeding around the prostate itself. So if we can have them stop the aspirin, and certainly if they're on blood thinners like Coumadin or Plavix or another blood thinner for another particular reason, whether it's a heart condition or they need to get their thin blood from a blood clot or something along those lines, we would like to get them off of that to minimize the chance of bleeding. And so make sure, and sometimes, again, supplements can also do the same thing. So we try to minimize those by getting those patients off of those medications. And again, if you look from a aspirin wise, you're okay within about 2 or 3 days. You don't necessarily have to be off of it for a week. So let's go through the questions that you need to ask your doctor. He's told you, hey, I need a prostate biopsy. Number one is, are you going to be able to put anesthesia or anesthetize around the prostate? That's called a local anesthetic rather than a general anesthetic. A general anesthetic is actually where we put you under anesthesia. And again, that's done in the hospital. That's more costly. And again, if you actually get a urologist who does many of these procedures and is good at doing local, where you just inject lidocaine around the prostate, those patients can actually be very comfortable. That's one. Number two is, what antibiotics are appropriate for me to minimize my chance of getting an infection? And three, what can I do to minimize my chance of actually having bleeding afterwards? So that's where you go into this. Okay, so you get the biopsy, and let's say you have the greatest urologist in the world, and you don't have a problem, and you say, wow, this guy's the best thing since sliced bread. But then all of a sudden, the next day, all of a sudden you start feeling crummy, and you say, geez, I'm sort of getting kind of like flu symptoms, or I'm starting to get a little bit of a temperature. You need to call your urologist. And the reason why is because you may have started to develop an infection, whether it's 1, 2, 3, or 4 days afterwards. And the sooner the urologist knows about this, the better that urologist is going to be able to treat that infection. So you want to make sure that everybody's on the same board, on the same plan on this, because if we find that you have an infection and we find it, within the first 24 to 40 hours, a majority of the times we can actually then put those patients on a different antibiotic and minimize the chance of them actually requiring to be admitted to the hospital. There's always the risk that it goes to the next level. And the next level is patients at home, they start getting fevers and chills. They start feeling really crummy. They're throwing up. At that point, we got to get them over to the hospital, because what happens is they're starting to get septic. And septic is where you get that bacteria in the bloodstream, and it's really starting to release those endotoxins, and that's starting to cause those high fevers and chills and that shakes. And we really have to worry about those patients actually getting much more sick. So we've got to get those patients in the hospital. Hopefully that never happens. And I think if we take it as a step-by-step process, again, just like at USMD, our risk of this is extremely low. It's less than 1%.
Some prostate cancers are high risk, aggressive, and more likely to spread. Others are low risk, least likely to have bad outcomes. The biopsy says cancer, but current diagnostic tools provide limited information about how aggressive a man's individual disease is. So most men decide to treat prostate cancer immediately. Once treated, many men experience serious long-term side effects, like incontinence and sexual impotence. Immediate treatment isn't always needed, but right now a man can't be sure if his cancer is the kind that is likely to require treatment, or if he's okay to wait for now. What if there was a test that could determine how aggressive prostate cancer is? Genomic Health is developing a new test to do just that. By reviewing the underlying biology of the tumor and using genes from multiple biologic pathways, the test can predict the aggressiveness of prostate cancer when diagnosed, allowing a man to make a more informed treatment decision with confidence, taking care of himself with more information and greater peace of mind.